So can you see my slide? That last night, that was terrible. So that so that yeah, that is now on time. So that we're gonna start on the APWA webinar. Then that Wendell and I will organize and moderate this webinar. I would like to firstly include our society, Asian Pacific Status Creation. So we can actually have a target of the our society, then that we can educate a group of surgeons each other in the Asian Pacific region using the caliber or annual congress or webinar. Then that's now that we're gonna have the forum on the website. 2015, we're gonna have established our society. Then that we had a Congress meeting in the Beijing 2016, others 2017, 2018 Narita, 2019 Seoul. Last year that the Singapore meeting has postponed to 2023, but we did have an first webinar on the January 16th. Then this is the second webinar. Thank you. So we're gonna start the session.
Wendong.
Yeah.
So Wendong, could you start the session?
Yeah, shall we start the session? So
yeah, we are live. We can start the session.
Yeah. So this is I think this is a very good start from the APWA and the IWAS combined webinar. So this yesterday we have the IWAS part, and today we will have the APWA part. So this is the main time today is about the scapholunate instability. So the first speaker is just Bain.
Wendong, thank you very much. It's nice to be with all of you at the moment, particularly during this difficult time. It's nice to see so many other friends, and we look forward to spending more time with you. I think this is a very special day, the first of the APWA-IWAS combined webinars. It's a historical event. I think it's an important advance in the concept of education at a global level. So we're going to talk about scapholunate instability, anatomy, and biomechanics. I'd like to acknowledge Melanie, who's my co-author in some of this work, who's done a lot of the graphics. With regard to the anatomy, I think all of us are familiar with the fact that there's a thickening of the dorsal and volar aspects of the scapholunate ligament and a
Sorry, we cannot hear you.
Can you hear me now?
Yeah. I
Oh
can
no,
hear
it's good. Yeah.
Thank you. Sorry about that. Can you see my full screen?
Yes.
Thank you. I'll push on. So with regard to the anatomy, I think we're familiar with the primary aspects of the scapholunate ligament, the thickening of the dorsal and volar aspects. Christophe has helped us with understanding how this relates together. I think this looks like the frenulum in the mouth, in the upper lip, and we can see how this provides a tethering point onto the dorsal aspect of the scapholunate ligament. If we look at these impressive images, and I'd like to acknowledge Gupta, we can see that the dorsal radiocarpal and DIC ligaments provide support across the dorsal aspect of the wrist, but we can see that the scapholunate ligament tends to be bare and is exposed on the dorsal aspect of the wrist. The DIC spans right across as a tension band across the entire dorsal aspect of the wrist and captures that whole dorsal aspect to provide stability across the dorsal wrist. In this cadaveric model, we can see how in radial deviation, in the out of plane motion, the scaphoid is forced into flexion. So the wrist is going into radial deviation, but the scaphoid is forced into flexion. And of course, the lunate sits in that balanced position. So the scaphoid being out of plane puts it in a very unusual position. And it's probably not surprising that scapholunate instability and scaphoid fractures are not uncommon. There's been extensive studies in serial sectioning, to summarize them, we can see here that if you divide the scapholunate interval, you open the scapholunate interval by about
Dr. Bain? I think we lost him. He got disconnected completely, so he has to rejoin.
We lost Group A.
Yeah, I think his internet got disconnected.
Okay.
Yeah, he's joining back.
It says that the host has stopped it. Has stopped me.
Go ahead.
I'm sorry about this. So Garcia Elias taught us that there are
You
type
need
1.
to please share again, Professor.
Okay.
Yes, we can see.
Let me see. Okay. So with regard to going back to the simple techniques such as fluoroscopy, which we can see here, longitudinal traction and also ulnar deviation can be beautifully demonstrated with fluoroscopy. But where we're going to now is to use 4D CT scan, which gives us a better understanding of the kinematic aspects. But this is in patients with clinical problems, and it's not in cadavers. This is a balanced sharing of the load across the radial and central columns. That's how the wrist works. So if we look at scapholunate instability, we have this static image. And if we go to a clenched fist loading, we can see how the dynamic aspects will open. And if we have this scenario here, where the wrist is going through in a dart thrower's motion, we can see that the moving of the carpus as it goes through these different positions. 4D CT scan helps us define the kinematics of the wrist. Instability is not a static thing like we see on a plain X-ray. Instability is a dynamic phenomenon of the functioning wrist, which affects motion and loading. Scaphoid goes into flexion. In this patient with scapholunate instability, we can see that there's dorsal subluxation of the scaphoid and there's a reversal. So the scaphoid now is going into, instead of it going into flexion, is now going into radial deviation in the same way as the capitate and other bones of the wrist. And this here demonstrates the amount of translation that we have of the scaphoid. So going on now, we all talk about scapholunate stability as the scaphoid and the radius, but there's not much work done on the STT kinematics. And so this is the wrist going to radial to ulnar deviation on the normal on the left. And we can see that the trapezium and trapezoid sits on the top of the scaphoid, and there's in fact more flexion of the STT joint than at the radioscaphoid. That joint tends to be in a hyperextended position, and the real deformity is that it starts from extension and has minimal flexion. So if we look at the volar aspect of the STT joint, we can see here that this thickened capsule, it looks a little bit like the volar plate on a PIP joint. It prevents hyperextension at that joint. These images here are proximity maps. And basically what we do is we have a look at the carpus and we define the distance. And we can see that in this scapholunate instability, that even in ulnar deviation, there's point loading over the radial styloid. But in radial deviation, we can see that there's a large area of loading across the scaphoid and radial styloid. I'd like to share with you this concept about the scapholunate stability and ulnar translocation, and acknowledge Telesnik and Garcia Elias with regard to their work in this area previously. In this 4D CT scan, we can see and in this example where we have this ulnar translocation, we can see this is a really different sort of wrist, and this is a much more advanced and complex type of instability. These three wrists are completely different in their kinematics. We've done some work looking at the isometric points to try and better understand where we should put our graphs and put our points of attachment. And if you go back and look at the finer sections of the anatomy, we can see that the attachment points are more distal and more radial than what we had before. Since we've changed to these isometric points in a better way, we've been able to get better reduction and stabilization of our carpus. So we've covered many things, and it's a great pity about the audio problems we had there. But basically, of the wrist and how that these wrist bones move in different aspects of the carpus. So how do I approach my scapholunate ligament instability patients? So those patients who have a dynamic instability, I think Mathoulin's technique is a good one. It's less invasive. And in the past, I used to be very worried about performing a complex reconstruction. This is a less invasive technique, and I think this is a good option in this patient. In the patients who have a no longer use this, and we make small windows to insert tensionable anchors, and we make sure we get them into our interference, into our isometric attachment points. Since we want a translocation as well, this is a more complex problem. And I think a dorsal approach is not enough. We need to look at using stabilization techniques on the volar aspect. And I think Michael Sando's NFAB has a place, particularly in this more complex scenario. So are we there yet? Still fiddling around, and some of the things are a bit of a challenge, but I think we're just a little bit closer. Thank you very much. And it's a great privilege to be involved with this historical moment where APWA and IWAS do these webinars together. Thank you very much.
Thank you, Greg. Very beautiful presentation. Very good, very good PPT. Yeah, thank you. So the next speaker is from Beijing, Qisuitan Liu Bo, please.
Okay, good afternoon, everybody, and also good morning, our friend in Europe. Thank you, Professor Wendong Xu, for introduction. My talk today is talking about the arthroscopic assessment and a classification of SL instability. So I'd like to thank all these pioneers and my teacher, teacher and good friend as well in my journey to understand SL instability and also prepare for these slides. So when we start from actually 1972, Lynch and Dobbins published their landmark paper about traumatic instability of the wrist. And Lynch and Dobbins covered that carpal instability is a carpal injury in which loss of normal alignment of the carpals occurs early or late. It is symptomatic due to carpal misalignment under physiological load. And SLD is the most common carpal instability. It occurs due to injury to the scapholunate interosseous ligament. So this situation actually is not a single form. The spectrum is there. A symptomatic patient comes to your clinic. This patient is a symptomatic patient, but the only evidence of the SL instability is from the stress review. And this is another patient with a quite obvious static instability. So this is why we need some staging or classification for this difficult pathology. So Garcia-Ellis actually has come up with this staging system in 2006. He asked 5 essential questions. Is the dorsal SL ligament intact? Is the dorsal SL ligament repairable? Is the scaphoid malrotated? Is the carpus reducible? And is the cartilage normal? And with the answer of these 5 questions, he come up with the 6th stage for the SL instability pathology. And also our friend Scott Wolf in the United States actually has come up with although the natural history is somewhat unclear, but the concept of the spectrum of the disease could be a card or so-called pre-dynamic problem, and it could be dynamic instability, only possible to visualize in stress view, and then the problem could be static instability, either is reducible or irreducible. And when the condition developed to carpal collapse or DC deformity, and many of them usually is irreducible, and the problem could be a dislabeling arthritis with a long-standing slack wrist. So the occult or dynamic problem could be it's usually a dynamic problem, and for the SLD, DC, and the slack is usually a static problem. So the role of wrist arthroscopy actually is very useful, particularly in the dynamic or pre-dynamic condition where the X-ray or stress view is all normal. In that situation, the wrist arthroscopy can help us a lot to assess the integrity of the both intrinsic and extrinsic ligament. For the static one, the wrist arthroscopy could also play a very important role to help us to identify the extrinsic ligaments, the cartilage condition, and so on. So the arthroscopic assessment is quite essential in the scapholunate instability. William Geisler actually has his very famous classification for carpal instability, particularly very useful in SL instability. So this is the Geisler grade 1, with SL ligament stretch. You can see from radial carpal joint, there's a ligament bulging or hemorrhage there, but there is a tight concrete SL interval in the metacarpal joint. So Geisler's grade 2, there's more SL ligament stretching. In metacarpal, you can see some incongruency or step off there, and a slight gap, usually less than minimal 1 millimeter gap of the probe is not possible to go into the interval. And Geisler grade 3 is you can see there's a obvious incongruity or step off both in radial carpal joint or middle carpal joint, a 1 millimeter probe can pass through the gap quite easily. In grade 4, you can see a large SL gap both from the radial carpal joint or from the middle carpal joint, and also a 2.7 millimeter scope can pass through the gap from the middle carpal to radial carpal joint, which is shown at the video here. So when compared to the ALS to Geissler classification, actually Geissler grade 1 to 3 are all part of ALS stage 1 SLD. That is attenuation of scapholunate ligament or partial tear of scapholunate SL ligament. And Geissler grade 4 is likely ALS stage 2 or 3. And our friend from Europe actually has a more modification of the Geissler classification by actually subdivide the stage 2 and 3 into more subtypes, including volar and dorsal and the complete passage of the passage of the probe to the SL interval. I found this is quite informative and quite useful classification to detect the specific volar dorsal pathology. This example for IWAS stage 2A, you can see a volar passage of the probe in the SL also without widening, but there is a tight dorsal SL interval there. So this is also give you more information about the decision making for this kind of pathology. So it seems quite confusing if you are a newcomer for this difficult problem. But in my personal practice, I try to remember and ask me the 5 key questions of the Garcia-Ellis classification in my thinking around SL injuries. And I find it easy to include the concept of dynamic, static, reversible, and reversible and static irreversible injury into the different stages of SL instability. And I use Geissler or IWAS classification naturally, or I find SL tear arthroscopically. So what's new when we come to the new center in 2020s? So in early days, it seems that most of our work and most of our interest actually was focused or limited to the SL interosseous ligament itself. But particularly in the last decade, actually more and more researchers or pioneers actually have found the more important role of the extrinsic ligament. Christophe Mathoulin actually has taught us the concept of the DCSS, the bridge between the dorsal scaphoid trochanteric ligament and the SL ligament itself. It seems to be essential to the SL stability, and probably its tear could be considered as the first stage of the SL stability. And also the radiologist actually has found the evidence like showing this MRI with a patient with SL instability and DC deformity, and you can see there's a tearing of the DCSS here, which is here. And also our friend from Australia has also come up with a very important concept which called this is a coronal plane control of the neonate. It's the more so-called mooring line theory that actually the coronal plane of the neonate is controlled by all the capsular or extrinsic ligament, which like the mooring lines for a boat at the harbor. So this is MRI have shown that this is a intact dorsal attachment of the capsular or extrinsic ligament to the dorsal neonate, and this MRI shows a stripping of the dorsal attachment of the over the dorsal neonate. So arthroscopically, nowadays we need to actually assess more things. We need to looking for more detail of these intrinsic extrinsic ligaments, which is you can see on the video here. There's actually a disruption of the DCSS from a radial carpal joint. And also, we also need to assess more than SL ligament as well. This is a patient with grade 3, Gessler grade 3 SLD patient. You can see there's a preservation of dorsal attachment of the extrinsic ligament here, which in this situation, we may consider the arthroscopic repair like the Mathoulin method of repair, which is my preferred method for this kind of patient. And this is a patient with Gessler grade 4 SLD patient. You can see there is a stripping of the dorsal attachment of the capsular ligament over the neonate. This is so-called dorsal neonate bell area. This is a typical sign that the attachment of the extrinsic ligament on the neonate is gone. So it's logical we need a reattachment of this kind of attachment or insertion over the dorsum of the neonate. So in summary, SL instability, the arthroscopic assessment is one of the key steps for staging or classifications. It could be useful for both all the present classification of staging systems. And new anatomical finding and a new understanding of SL instability have shown that in the past we are too much limited to the SL ligament itself. Now we have more understanding of the DCSS. We have more understanding of the coronal plane control of the neonate. So we need to assess and identify the pathology of DCSS and also the attachment of extrinsic ligaments arthroscopically. So thank you very much for your attention. Welcome to Beijing this year, where we will have a 10-year anniversary of a reconstructive course in Beijing. Thank you very much.
Thank you. So the next speaker is Christophe Mathoulin, who will talk about the scapholunate tears from open surgery to arthroscopy.
Okay, hello, my friend. The first thing, I'm really happy to be there, you know that. And I hope that we can come back to the face-to-face congress, face-to-face course, because I miss you really. And if ever, my dear friend from China, if you ever you manage to relax the musers to come in your country, it will be very great. And I hope that the next APWA meeting in 2021 in November will be a great meeting with all of us together to share the better moment we can have after this terrible period. So you know that I'm really happy because it's an IWAS and APWA meeting, and we are very close each other. And you know that for me now, all the AirCAD course we organize will be, of course, with the IWAS, but also with in partenariat with the APWA too. And it's a very important symbol for our future. So I would like to congratulate and to thank you, all of you, to be there. So we have to discuss about the scapholunate ligament tears from open surgery to current treatment. And in order to understand the big leap we have made in understanding this instability, we have to go back over history. And we start by the period one, I call that the pioneers. And you know that Dobbins and Lynchild from Mayo Clinic was the first guys to describe this problem with subluxation, rotary subluxation of the scaphoid. At this period, we believe that this part of soft tissue was the scapholunate ligament, was the important step in stability. If you look carefully this area, you see that the color is not exactly the same as the other part. In fact, it's because this area is an unvascularized area. And for a long time, we perform a beautiful operation like that. Thank you, Mark Garcia-Elias, for these pictures. And in fact, we obtain a very bad result, and we believe that the repair of this area was good, and unfortunately, it didn't work. So it's why rapidly, you see, since 1975. Yes.
You just open your slides, or just we cannot see the slides.
Ah, you cannot see the slides. It's a pity because I share. Check. Yeah, yes, I share.
Just unshare and share again.
Hello, okay.
Yeah, we're gonna have a list of your videos and also the list of the PowerPoint.
Share. Hello, so I try to redo it.
You can share now.
You have to open.
Yeah. You see something or not?
You have to open the PowerPoint file first.
Yes, it's down.
And
No, you're sharing your desktop. You have to share the PowerPoint file.
Right, sorry.
Share again.
Yes. So
click on the share. You'll find your PowerPoint in that window. Click on the PowerPoint.
Okay. Do you see?
not yet.
Not yet.
That's a thumb drive.
Okay. Why? So I stop. I redo it. Do you share? Do you see something now?
No.
What the pen? Normally it works very well. It's curious.
Okay, just unshare again. And once you click on share, there is a window that opens.
Sorry. I stop.
Yeah, right.
Okay, so you don't see anything. So now I go back to that. You see or not? Because my computer, right? There is a sharing of no problem in sharing. It's why it's curious.
We are not seeing it now, but we saw it in between for a brief moment. So just click the share again. Don't click on the screen. Find your PowerPoint. There is a window that opens.
Okay.
Yeah.
Okay. So let me come back completely.
Yes.
Do you see something or not?
Yes, now we see it.
Yes.
It's okay?
Yes.
Okay. So I do that, and you
can go to PowerPoint mode. Yes.
It's okay?
It's okay.
Yes, perfect now.
Perfect. Okay, so I continue. So rapidly, the surgeons created some ligamentoplasty, and you see this first ligamentoplasty very close to the current ligamentoplasty proposed in 1975. But unfortunately, in the majority of cases, this ligamentoplasty didn't work very well because the arthritis appears very rapidly. So because the surgeon was clever, they tried to find solution with the blood capsulodesis, different ligamentoplasty, until Brunelli in 1995, explaining us that the instability, the majority of cause of instability was from the STT volar ligament, and he proposed this ligamentoplasty, and we believed it was the solution was there. And we arrived to the second period of the specialist, and you know the classification from by our friend Geisler, and the change we have performed here, and until the proposal by Mark Garcia-Elias, And we are all with trouble to understand what is the difference between the Garcia-Elias classification, the Geiser classification. It just because the problem is not solved and not so simple. So we have seen different procedure, the Russell procedure, the bone ligament bond by Philippe Queneau from Geneva. Myself, I propose open surgery, and we arrived to the free ligament tenodesis proposed by Marc Garcia-Elias, and it was the second step. We believe that the solution was there. Unfortunately, Marc Garcia-Elias himself explained that this free LT ligamentoplasty was not the solution in all cases. It could be an help, but it's not the solution in all cases. And it's why many different proposals has been made by Ross, Corella, Diego Fernandez, Andrew Chin, etc., etc. So where are we going? Is it reasonable to believe that a tendon will ever become a normal ligament? Of course not. Will it ever contain mechanoreceptor? We don't know because the nature is so strong, but it's not sure. Will it be able to resist the amount of tensions and torques involved in the joint? Of course, probably not. So we arrive to the second period, is the anatomy period. So the first step to understand, it's very important, is that the volar STT ligaments are very strong. In my life, during 5 years, pushed by Kapanji and Kuhlmann, I systematically opened the volar STT joint, and I have never seen a real rupture, never. And when you have to remove the scaphoid in slack procedure to perform a first row carpectomy or four-bone fusion, you have always a problem with the volar distal attachment, which are very strong. We understood that the flexor carporadialis, but not only the flexor, all the extrinsic tendon are very important in stabilization also. And at the end, we have understood that there were in fact three parts in this soft tissue surrounding the scaphoid and the lunate: the dorsal ligament, a volar ligament, and something in between. And we understood also, thanks to Mataliotakis and Marc Garcia-Elias, the importance of the innervation. In 2004, Gamal Zaidi published a very important work obtaining in laboratories instability and the rotatory subluxation of scaphoid only after the detachment of the dorsal intercarpal ligament. It's very important. In my life, in my current practice, you see there is some instability with the normal ligament. It was a surprise, but when we see the dorsal aspect, you see that there is a detachment of something at this period. We don't know exactly what it was. And look at this small stage 2B instability. The ligament, the scapholunate ligament that we call the scapholunate ligament is intact, and there is a rupture between the dorsal capsule and that. So it's why we performed 2 days of laboratory work with the international team, and we obtained a systematic worsening of scapholunate diastasis after just a simple detachment of DCSS from the scapholunate ligament. We perform publication with a different anatomical description of the tears until the anatomical work published with the international team, and we discovered that it exists a bridge between the dorsal capsule and dorsal scapholunate ligament. We call that with Marc the dorsal capsuloscapholunate septum, and it's essential instability. So in summary, in fact, there is 2 bones. There is a dorsal ligament, a volar ligament, there is an extrinsic ligament, and there is a bridge between the dorsal capsule and the dorsal ligament, and the volar capsule and the volar ligament. In fact, it's just logical. So we are not totally in the same position with Marc according to the repairability of the ligament, and the arthroscopic surgeon push the repair, the possibility of repair when you see something to be repaired. Mark added a sixth question: is the lunate uncovering index normal? And we arrived to this classification, the pre-dynamic, dynamic, and static, and we have to ameliorate that. Arriving to the proposal I've made a long time ago about the dorsal suture, and Max Haerle later will show you the techniques. The most important is to see that it changed completely the result, and you see all these sportmen or sportwomen became world champion or gold medal after the repair. It was impossible before by open surgery. So I would like to share with you this case. It's a very interesting case because you see the instability is a very large instability. We call that APWA-IWAS 4, Geisler 4, Garcia-Elias 4, what you want is not important. Look at just the dynamic, the mechanical effect of the suture with the reduction of the DZ in this case. I was not happy with the stability. I continued in this period to put some CAWAs that I have abandoned now. And when I remove the CAWAs, I was surprised to see the intermediate part of the scapholunate ligament non-repair is logical. But look at the dorsal, you remember the big instability, and look at the dorsal repair just after 2 months. It's very close to the normal aspect. So it means the nature is very strong, and we have to push to be repaired by itself. And you see this clinical case, the same clinical case after 9 months. When we perform the MRI, we have seen a very beautiful automatic repair. And of course, the patient has very good result with a good stability, good strength, and a good range of motion. It was a professional tennis player, and now he's retired as myself. So Paco describes the volar technique, and PC the very fantastic but technically demanding reconstruction with the tendon graft. Where are we now? We have to understand that the interosseous ligament we repaired before is unuseful, and we don't have to take into account this problem. Here you see this patient operated 3 years before. He has no intermediate ligament, and the stability is absolutely perfect. So what is the real importance of proprioception? We act on proprioception where arthroscopy repair is sure. Does the distal volar ligamentous lesion exist? I can tell you no. Stop with the STT ligament. Are isolated lesion of DCS a pre-unstable lesion, or are they another entity? Yes, the DCSS could be considered as a pre-unstable lesion, but the most important, and we arrived now to the fourth period, which is the scapholunate ligament complex. And Mark Ross arrived 2 years ago in the Guillaume-Ellsberg Congress with the question, and if the primary stabilizer was the extrinsic ligament. I think it will be the question for the future, your question, of course. So at the end, we have to believe in nature, which is, of course, stronger than us, and learn to use it. When you put a plate on a bone, which is the bone, of course, is not the plate, it's the bone itself. It's the same for the ligament. We have to learn to use the nature and to require the good technique. So we have to understand that the scapholunate ligament complex is a new concept. The importance of extrinsic ligament should be demonstrated in future. The early diagnosis is requested, is why it's very important to perform the dynamic comparative X-ray. It's very sufficient in majority of cases. And arthroscopic, capsulo-ligamentous repair, dorsal volar, etc., push the open ligamentoplasty in a very small part. Thank you very much.
Thank you, Christophe. Now that it's on time, so we're gonna have 15 minutes to discuss about that. Firstly, that I would like to ask all three speakers have discussed each other. Is Greg here or both?
Yes.
do you have any question or comment on the other two topics?
Yes, actually, one thing I'd like to say is myself and I think Christophe had some technical difficulties, and I would hope that we can record them to put them back on the website. I think that would be a very useful thing. Christophe, can I ask you how often you use the volar capsulodesis as well, or do you only majority of times just use the dorsal approach? How often would you add the volar approach with your technique?
Yes, it's a very interesting question because logically, we have to repair the dorsal and the volar when you have a large dissociation. In my practice, it's less than 5%. Why? Because when you reduce correctly the scapholunate joint with a different maneuver, and very often with a simple dorsal suture, you manage to have a stable scapholunate space, and it's not necessary to reduce to repair the volar. I would like to remind you, a few years ago, we used simple KYs in acute scapholunate lesion. And Thierry Whipple explained us because he believed there was the creation of fibrosis along the way of the KYs. It is not that. In fact, we reduce the anatomy, and after that, the nature was repaired, but creates the reparation by itself. And in fact, if you obtain a good stability by the simple volar suture, for me, it's enough. I don't open volarly because you have to open a little more to make the correct volar suture, and it's not necessary. But in some cases, I have to do the both suture, volar and dorsal, but it's less than 5%.
Just like to go back to the comments about STT joint. We've looked at the kinematics of that. It's very interesting. So I think we're all familiar with the scaphoid going into flexion. But while the scaphoid goes into flexion, it means that the STT joint is effectively going into hyperextension. So I agree with you that our experience is that when we look in the STT joint, we don't see ligament injuries. But I think there's a secondary contracture of those ligament structures. And I think that's an important reason why some cases it's difficult to bring the scaphoid back down and to reduce it to be anatomic.
You're right. You're right, absolutely. But I promise you, I have made that for 5 years. I systematically opened the scapholunate. It was a period in which we operated only the static case a long time ago. And I systematically opened the STT joint. I have never seen the real rupture, elongation, of course, but not real rupture. So I do a suture of the STT like that, you know. I put a staple, but it created more problems than solve the stability.
Can I make a comment?
Yeah.
Yes.
Thank you. I think it is very good to point out that a lot of time in chronic scapholunate problem, or even in scaphoid non-union with a humpback deformity, we see contracture of the STTJ. Particularly in arthroscopy, you can appreciate very much. Sometimes it's very difficult to put the instrument to the STTJ, more difficult than usual. It must be due to something happened in the STTJ, and I think the explanation of contracture is more likely rather than the ligament attenuation. So I echo the comment about Greg and also Christophe. Second comment is about the staging of the IWAS. Because the staging should carry some prognostic means and also guide for treatment. And I actually appreciate the subdivision of stage 2 and stage 3 of Geisler into the IWAS, into the A, B, C, which is dictate the volar, dorsal, or complete one. There's some comment. First of all, I don't know whether we should really call it stage or using the type, because stage 2 and 3 is a progression of the severity, but A, B, C actually represent the specific location of the tear. It may not be progression of the the injury. So I would just wonder how should we name it into a better alignment. And secondly, if Christophe saying just dorsal repair will also work for the volar tear, means 2A or 3A.
Excuse me. You're right. I mean that if there is a volar lesion alone, of course, it's a volar suture. Sorry.
I see. But what I try to say that if there is some volar injury plus a dorsal injury, on top of your dorsal repair, which is your standard, would there be a role for a pin across SL joint? So at that part will actually help to protect the volar side. Would it be more rational to do it this way, or when you just a dorsal tear, just dorsal repair, no pin? But when you have dorsal tear, what's plus a volar tear, acting a pin, is it a logical choice?
Yes, you know, and from more than 3 years, I didn't place any cowars. I stopped that. It's not necessary, in fact. And even if it exists a small instability, if you manage to obtain a good position of the scaphoid and the lunate is sufficient. I don't put any cowars because the cowars creates a iatrogenic problem very often. It's complicated to perform that. So I prefer not to use the cowars. You're right. The suture, the reconstruction of anatomy is very interesting, and it's why I love your technique, because your technique is reconstruct the extrinsic and intrinsic ligament in one stage. It's very interesting, dorsal and volar, so it's very interesting.
Yeah, I think that this region at Watson actually describes that the sequential tear from the volar side, but dorsal side, but sometimes that I saw on the dorsal part rupture only, so that it's not a sequential, or so that is why that I agree with PC's comment on that. Guys are using a grade, then that some are using the stage, but maybe that if there is a tear on the side, then we're gonna use a class or something.
Yeah,
that's much better. So
in fact, you know, it's
class 3C or something.
Surgeons, we love to create classification, but in fact, we know that they are not real, because the real life is totally different. We find different solutions. There are other things I would like to emphasize. It's very important that particularly in young people, we can see some young people with instability when we enter in the joint. It's particularly true for the TFCC, but also for the scapholunate. We see that there is almost a normal aspect, because sometimes the nature tried to reconstruct the patient whole life, of course, and try to reconstruct, but the reconstruction is not good or not sufficient to obtain a good stability. And it's why with the probe, you have to push smoothly, and you see that the false repair disappear completely, and you have to do the suture correctly after cleaning with your shaver. It's very important, because particularly in TFCC, very often I have to reoperate some patient already operated. The first surgeon say arthroscopically the TFCC is intact, and in fact the patient continue to have pain. And when you arrive in a peripheric dorsal medial part with the soft hand of your probe, you can destroy completely the false repair. It's the same for the scapholunate.
I think it really highlights this point. Yep, I just want to continue on with what Christophe's telling us and teaching us. I think it's really important that we try and identify what the pathoanatomy is, what the abnormal anatomy is, and it may not fit into exactly a classification. The classification is a guide, and then try and put the findings of arthroscopy, MRI, and the clinical history to try and get a better understanding, and then address all those. I think we have a chance of winning then.
Complicated to answer that, you know. Bo.
Hey, Greg, may I have a question?
Yeah.
Greg, are you here?
Yes.
Yes, very beautiful presentation. You use the 4D CT scan.
Yes.
This is for me the first time to see such kind of the technique. Very beautiful. Could you please explain more details about this technique?
So we're all familiar with the CT scan. A 4D CT scan, in a normal CT scan, the patient moves through the gantry, and we get pictures of the lumbar spine at different levels, for example. In this, with a period of time, so that we can see the image at 1 second, 2 seconds, 3 seconds, we actually get 4 images per second, and then we can move the wrist in that time frame and get images which are basically a mini CT scan. So today we've shown you some examples of like the 3-dimensional view through time, plus also there's almost like a fluoroscopic view or a narrow slice view. And then the other area that we've been working on where we've been able to take the STL files, the surface rendered files, and been able to then do some computer analysis of them to understand how much each bone is moving in 6 degrees of freedom. And the thing that we like about this is it's for the first time that we've ever been able to truly quantify what's going on with the scaphoid or the lunate. Previously, we've looked at images and got some understanding, but now we can measure it down to the degree. And I think it's about then understanding which groups there are. So you might remember the image I showed of a normal scapholunate, then one with dynamic, and then where this lunate was just all over the place, where there was ulnar translocation of the carpus. You know, that's a completely different injury. And this is a difficult problem. And so I think we need to get better at defining each of these groups. And I think the 4D CT scan helps us do that.
Thank you. Thank you.
Yes, with Philippe Safar in 1989, we published a paper with the CT arthro radiocinema techniques. It was very funny with an incredible radiologist, and it was very interesting because it was before the apparition of MRI with the quality of image we obtain. And with this exam, we see the passage of liquid through the different problem, but in fact, we don't have to forget that the central part of the anterior ligament was nothing. So sometimes the liquid can pass, but it doesn't mean that there is instability.
Hi, Greg. Can I ask you a question about the motion during the 4D CT scan?
Yes.
Yeah. So, do you perform only radial ulnar deviation? Only you can also check the a fist. The patient can make a fist while performing this kind of CT scan. What kind of motion do you prefer to check instability?
So, Fernando, thank you. Very good question. So we have a routine of doing flexion extension, radial ulnar deviation, pronation and supination, and we get them to do dart throwers as well. When we first started, we did all of those things. Now we try and just be more accurate and more direct to what the problem is. We published a paper in the Journal of Wrist Surgery about 3 years ago, which is what we call the clinical utilization. And really, the paper is designed to allow you or the other surgeons to be able to apply this, because there's some issues with regard to how to store it, how to do the imaging, radiation dosage, all those things are there. So the Journal of Wrist Surgery, clinical utilization about 3 years ago. So that may be of interest to you. I'll put it on the chat line, the reference, so that you and others can look at it.
Okay, thank you very much.
Do you have any questions? Audience, do you have any questions? If you have it, then you can use in the chat function. Then that maybe later that Greg and then Bo and Christophe will actually answer your question. So please stay tuned. Then the next session will be more clinical application, which is a injury. Then the Max you will organize the session with Greg. Okay, so please move forward. I can't hear your voice, Max.
Okay. Can you hear me now?
It comes.
Oh, it's okay? Okay.
Sure.
Thank you very much, dear friends. Good morning from Europe. We are in the early morning times, and it's a great honor for us for the first time to have this online version of APWA and IWAS all together. And I think it's a great honor, and thank you all of you for organizing that for us. It's a great event, and it's a great honor for all of us to be here. And I especially appreciate the moment we share all together in these times where we can't meet, and for so many months we didn't meet, so it's a real disaster. And on the other hand, it's good to see all of you. You're well and safe, and we are all there, so we are waiting for reunification. And that was a great session, Toshi. Compliments, and Greg, and I think we should start. What do you say, Greg?
Thank you.
So I'm going to introduce you, Max. Max is the Secretary General of IWAS. He's well known to many of us. He's made major contributions, and he and Christophe have really changed our understanding of scapholunate stability. So, Max, would you like to give us your presentation on arthroscopic dorsocapsular ligamentous repairs?
Yes, if somebody could allow me to share the screen, I would be happy. Okay, I'm doing it now. Let me see there. Can you see the presentation?
Yes.
Oh, good. So
Yes,
now the only thing is I have to move away this. Perfect. So I think you have heard quite a number of things already on this technique. The scapholunate ligament, for repetition for those who are more new to the concept, is not is for many years the interosseous ligament we have seen. And these interosseous ligaments give great instabilities to the scapholunate ligament, and these great instabilities for a long time have given us a lot of headaches because we could not stabilize the situation. We did not understand which ligaments are involved, and at the end many techniques have been proposed without having one good technique or a common understanding what happened. And in this very disturbing circumstance where we were all unsafe, Christophe Mathoulin had this great idea to suture the ligament and to arthroscopically. And at the beginning, people were a little skeptic, myself too. Why could we suture something by arthroscopy which we cannot suture by open surgery? And so we thought about a lot of concepts, and we found out that Christophe's techniques works very well, and it is probably due more to the healing of this dorsal capsular complex, and this is why, again, these pictures of Dr. Pallier from Rome are very interesting, which Christophe also showed. They are very interesting because they come from a time which is much prior to our understanding of these dorsal capsular ligaments. And you see here this very strong capsular reinforcement, which is going along the dorsal ridge of the scapholunate triquetral system, and you see that the scaphoid has a ridge here. The scaphoid has a ridge here, and this ridge is to attach the dorsal capsule, and the dorsal horn of the lunate has the same ridge, and the triquetrum itself too. So that's where all the stuff here attaches, and Christophe has already described that only if you detach this dorsal attachment of the dorsal capsule to the scapholunate complex, then you get an unstable situation. If you just cut the interosseous ligament itself, it's not gonna give you that the same experience. And again, these old pictures, which were done to show the palmar STT ligament complex. If you look closer, that's the dorsal part. So that's the interesting thing. And so what we hypothesized quite soon, that it would be good to reapproach the two bones by using the remnants of the dorsal DCSS to or the dorsal capsule to the scaphoid and the lunate, and get a healing of this dorsal capsular complex rather than the scapholunate ligament itself, which in my view has to be proven that it has a potential to heal, to have a capability to heal, because I think it is very poorly vascularized, and we know from other ligaments and stuff that they don't heal even if you reapproach them. But this is a concept which has to be proven. So this is the situation. This is the problem, and that's how we approached it. Once it is ruptured, so unfortunately these videos don't part. That's a big problem. Well, this is a case. I don't understand what's going on here. This is a case of Geisler 4 ligament injury, and you have a complete instability of that little space and a dorsal detachment of the capsule. And you see now the technique consists in going inside with the suture into the radiocarpal space, once over the lunate and once over the scaphoid, armed by a suture. You go from there into the midcarpal space on the dorsal part of the lunate and on the dorsal part of the scaphoid, and you insert these sutures inside the joint, and you can, by a loop technique in the technique I use, this is a little different from Christophe's technique. You can, by this technique, insert a loop technique and bring through the suture. And the most important fact here is that you have to refresh the dorsal capsule with a shaver. That means you have to refresh the dorsal capsule at the midcarpal joint and at the radiocarpal joint in correspondence to the scapholunate ligament, and you have to refresh it such that there is a recreation of a fresh lesion. We have started in random cases also to refresh a little bit the attachment of the bone, which is in the non-articular, in the cartilage area, to get a refreshment of that area from a bony point too. But the most important is the capsular refreshment at that point. And then you make this loop technique, and by the loop technique you can practically bring together the two bones and to put them in their natural position. And they go naturally in their position. There is no need of help of any K-wires or anything. Generally they go there and stay there. And it's then you can generally unload the wrist from any distraction, and you get a very solid fixation here, and then I cast them for about 8 weeks. Yes, it's a long time, and I do not train them by physiotherapy immediately. I let the ligament heal, I let all the complex heal, and generally they have a little lack of flexion, but a very small lack. And I mean, what they gain from that lack is stability, and so that's the most important thing. So we have already in 2018 seen that we have almost 100 capsuloplasties done, and with a good follow-up, and we have seen that most of them are in Geisel 3 and 4. At the beginning, we did some K-wire transfixations, which we do not do anymore. You see the distribution in our APWA-IWAS classification, and we had some failures, and the failures now are up to 5, and the failures are the more unstable cases. That means probably we have treated cases which were really very unstable and did not merit this technique. And if you go look to the X-rays, and there we come naturally to the problem, that X-rays are quite a problem at that stage, because preoperatively this is a minimal opening and it is difficult to evaluate. The Geisel 5, they are not doing so good as I told you, because there are the failures in these cases. But for all the rest of the patients, we can see that there are excellent results of this technique, and people are really happy, and it was a change, a real change in our paradigm of treating scapholunate ligament injuries. So yeah, why didn't we get these results at the beginning? Why didn't we achieve this? So I think with the open surgery, and I mean, there were many bright surgeons trying all this in the beginning, and they taught us to go to the wrist and this and that, and that was everything. All these efforts were very glorious, but naturally the open approach did not respect these capsular structures, but did probably lead to a more unstable situation than it was before. So ripping off all the capsule from the wrist is not a good idea from this perspective or hypothesis we have put, that the scapholunate ligament complex is a complex to be restored. And this is why probably the same technique could also work in case of any open surgery. And also the denervation of the wrist at this level is not helpful, because, as you know, I'm a good friend of denervation techniques, but we need the activation, reflex activation of the secondary stabilizers, and by ripping off everything, we lose them. So I think this arthroscopic techniques is very helpful. And when we look where were our patients, we see here that the majority of the patients, almost 80%, were in 3B and 3C APWA-IWAS. And in these cases, this dorsal capsulodesis or suture whatsoever give excellent results and stable results. And in those more advanced cases, it can work, but there is a limit. And where is the limit? So this is probably when the dorsal capsule is detached from the lunate or scaphoid. In my experience, it's much more the case that it is detached from the scaphoid rather than the lunate, or you have a real greater instability, like a lunotriquetral instability, which goes with it, then you get real unstable cases, and then it's getting critical. But the question is, would you, in a primary case, go directly for secondary reconstruction, or would you try to go for a capsulodesis? So this is a point of discussion, but I mean, then we can go to the people who have much more interesting cases. So if it is a major detachment, for example, from the scaphoid, What we have done recently is that we refresh the bony area and then we go there with a little anchor. Generally, I place it more proximal, the anchor, that the design was more driven by theoretical experience, but Greg has showed us that probably it's more proximal where we have to put it. So that's what we do. And you see here that then you can do a capsulodesis on the top of all this and try to combine the classical suture with the capsulodesis without disturbing the capsular attachments. And that has helped, but not in all cases. So we have failures also here, and that's the problem in long-standing scapholunate instabilities. Not everything may heal, but the dorsal capsulodesis or arthroscopic scapholunate suture, as proposed by Christophe, is a gigantic step forward in scapholunate treatment. The key lays in those dorsal structures. And how we can repair them. Well, I think we have a good chance to repair them for the limited instabilities, and for the greater instabilities and for the long-standing instabilities, we still have to see a future coming. Thank you very much for your attention, and I think we are open for discussion. Are there any questions?
Max,
Greg,
well done. Beautiful presentation.
Thank you.
So when you're looking at these more complex cases, what do you think the reason as to why they get the contracture? We said before, maybe it might be the STT joint. Well, have you got a thought on that? Have you got any experience, or what do you think?
I didn't get your question. Please say again.
So in a case that's, say, 2 or 3 years old and it's got a real DISI,
yeah.
What do you think are the causes of the contracture in those cases? Do you think it's that STT joint, or do you think there's something else going on?
The contracture for not being able to reposition the scapholunate dissociation. I'm not sure. I have more. I think the problems of the STT joint are more reflected. I personally see when I do, for example, a 4-bone fusion in a static old case, the DZ deformity of the lunate is so hard to correct. And I see that the volar horn of the lunate is kind of contracted there. So if I don't release the palmar ligament contractures of the lunate, I'm unable to reposition at a long-standing this lunate DZ deformity, and that's for me much more the key rather than the STT joint, which is more a reflecting point. But I mean, these are personal experiences and not truths.
Yeah. No, that's okay. If there's any questions, maybe they can come through. Just one other question is, with these, if the patient's got some arthritis, how much arthritis do they have to have before you say you don't do this technique, that you would go on to maybe a limited risk fusion or some other technique?
It is. Thank you for that question. That's a difficult one. At the beginning, I was more conservative, and I said as soon as I saw some cartilage loss, we're going for secondary. Now I am much more for, even if there is a partial, let's say 20% cartilage damage, I still try, because I'm in comparison, if it goes good, the comparison to what I achieve with a proximal row carpectomy or a 4-bone fusion, the results are so much better that it is worthwhile for the patient to give it a try. But you have to first see the patient, and then you have also to see what is his problem. I think by clinical examination, you are able to say, okay, this is a problem of an instability which causes the pain, the snapping of the scaphoid over the dorsal ridge of the radius, rather than a night pain or a pain without motion, which is a pain which rather reflects an arthritis, an osteoarthritis problem. So I'm trying to put things together, and I would say, to answer shortly, rather go for it and try and give it a try. The problem anyway is with a long-standing scapholunate instability and a beginning osteoarthritis, to get there, a stabilization of the situation is rather a difficult challenge. And this is why in a slack wrist, in a real slack wrist, if you try to do other procedures, it is critical, because once everything is stuck so much in that position, it's getting difficult. But Christophe has great experiences on resection arthroplasties combined to scapholunate reconstruction.
Okay.
Yes, I have a question for you, Max.
Yeah.
Because your loop technique is very interesting, but you know that my problem with the loop technique to restore the ligament was the weakness of the remnant ligament. So your principle is very interesting, to pass through the dorsal capsule distally and proximally. What kind of suture do you use for that? And you never have to problem with the quality of capsule? I suppose no.
Well, you know, to answer the second question, if I have a problem with the capsule, all the technique is not working. So that's what you have to check intraoperatively, if that stuff is attached or not. And I use a fiber wire, a 2-0 fiber wire. I have tried with all these PDS and stuff, but as they have an intrinsic elasticity, I think what I want to squeeze it really. I mean, I don't want it's going to move by itself later on. So that works for the moment, but it's more the technique then.
And
I think we have to go on.
Do you open a little more the freeform? Do you open a little more?
Yes, I open about a centimeter, the 3/4, and I open also by there with a very small incision the fourth compartment of extensor tendons to get them away, because if you put the suture around your extensor tendons, then the problem will be.
Of course, thank you.
Thank you.
We might, Max, very well done, lovely presentation. Christophe, thank you for your contributions there too. So I think we might go on. Joo-Yup Lee is our next presenter from Korea. He's a very active surgeon within APWA. He's a Secretary General, and we're very pleased to have him continue to be one of the young surgeons in the Asian area who really is stepping up. Joo-Yup, please share with us your presentation on the DIC reconstruction.
Yeah, thank you very much, Greg. Can everyone see my presentation?
Yes, we can, and we can hear you well too.
Okay, I'd like to talk about the arthroscopic DICL augmentation for dynamic scapholunate and lunotriquetral ligament tear. As discussed in the previous session, the scapholunate ligament instability is not a single ligament problem, but involved multiple ligaments that results in progressive arthritis of the wrist. Many surgical options have been introduced with mixed clinical results. Even with the newly developed anatomic procedures, sometimes fail with no obvious reasons. And I totally agree with Max that the capsular stripping might be the cause. I think there have been several concerns on current scapholunate reconstruction procedures as described below. Let's see one by one. Naturally, there are more than 30 degrees of rotation motion happening between scaphoid and lunate. And that is why, there's the reason why scapholunate repair is easy to fail, and the scapholunate fusion is very difficult to achieve. Most of the procedures are focused on repairing scapholunate ligament with proximal scaphoid hole, which fails to extend the scaphoid. As you can see in this picture, the dorsal capsule and DIC ligament is widely released, which might aggravate the scapholunate instability. I think the dorsal portion of the scapholunate interosseous ligament is only a pivot point or a gearbox of a car for scaphoid rotation, but we need an engine to actively extend the scaphoid, which is, in my opinion, is the triquetrum. Decreased vascularity of the lunate is also a matter of concern during the scapholunate reconstruction, and it may result in fracture or avascular necrosis with larger drill holes. I also found that the dynamic scapholunate and lunotricular instability is frequently coexisted in a same patient, which can be explained by Mayfield's progressive perilunate instability theory. Scaphoid and triquetrum avulsion fractures are sometimes identified in the sprained wrist patient like these radiographs. And this indicates dorsal intercarpal ligament has an important role on developing scapholunate and lunotricular instability. Here, I would like to introduce my arthroscopic procedure to stabilize scapholunate and lunotricular joint by tightening up dorsal intercarpal ligament. As Dr. Mathoulin and Dr. Haerle talked about the dorsal capsule ligament repair technique, DCSS plays an important role to connect DIC and scapholunate interosseous ligament. However, sometimes I found there are several patients who had a lax DIC ligament but relatively intact DCSS, as you can see in this video. So I decided to focus on tightening the dorsal intercarpal ligament, specifically the scaphotriquetral ligament, as described by Haggard. It's number 3. Open procedures for the dorsal intercarpal ligament reconstructions are well described in the literature, but I thought the arthroscope itself has many advantages to reduce the carpal deformities. According to Mark Garcia Elias, scaphoid is extended and supinated, and lunate can be radially translocated by axial traction. Once the carpal bones reduced with axial traction, I decided to put non-absorbable suture alongside the DIC ligament via STT and MCU portal, and fix the suture to the scaphoid and triquetrum with 2 anchors. Here are the ingredients of my procedure. I chose 1.3 mm suture tape, and it is passed with microsuture anchor from Athrex. To make a drill hole, I use blunt tip needle as a guide and 2.0 mm cannulated drills. For suture fixation, I use 2 push lock anchors, which is 2.5 mm in size. Here are the examples of passing suture tape with microsuture lasso. Viewing from the MCU portal, routine synovectomy and evaluation of the DIC ligament and scapholunate interval was done via STT portal. Firstly, a drill hole was made with a blunt tip needle, and KY was introduced through the needle. A cannulated drill bell was used to enlarge the tunnel. After changing the viewing portal, DIC ligament status and lunotricular interval was also evaluated. And make another drill hole to the triquetrum at the same manner. And I put the suture lasso from the MCU portal and tried to grab a part of the DIC, and it was fixed with 2 push lock anchors, to the one to the scaphoid and another to the triquetrum. This is the clinical example of this procedure. At the final follow-up, as you can see, the scaphoid is a little bit extended and supinated so that the distal part of the scaphoid does not contact with radial styloid. In the clenched fist wrist view, the scapholunate gap seems decreased in the final follow-up radiographs. Dorsal protrusion of the proximal pore of the scaphoid is also decreased. Combined TFCC foveal repair and ulnar shortening was performed with this procedure. The operation time was less than 2 hours. These are the clinical results of this procedure. I think this procedure can be indicated for the IWAS stage 3B and 3C scapholunate instability. Capsular shrinkage should be just fine for the earlier stage, and the volar, some type of volar reconstruction might be needed for the stage 4 or 5. Although not always indicated, this procedure can be effective for selective SNAC wrist patient who refuse to receive any type of partial wrist fusion. So in summary, I would like to introduce arthroscopic DIC ligament augmentation procedure for dynamic scapholunate instability. I have been doing this for more than 40 patients since early 2020, and the short-term results are very promising. And I hope I'm not making a bad situation even worse with this procedure. Thanks for your attention.
Joo-Yup, very nicely presented. When you use the push locks, you can't always get a lot of force on them. Can you bring that together, or have you got some tricks to help us with that?
First, in the beginning of making this procedure, there was some type of problems, as you mentioned. But after I make a drill hole to the with the 2.0 cannulated drill, and then the enough depth is also important. So after nowadays, it doesn't have any problems for me.
And does the suture goes outside the capsule between the two, so it holds the capsule down?
Right,
so,
right. Like
yeah,
this.
there's a band across the top. Okay, that's
right,
good.
right. Yeah.
So you will have to open a little bit to avoid to catch any tendons.
Right, right. That's the problem. So actually, I had one problem, one failure. But you know what? That's the. I tried to put the suture from the STT portal to MCU portal. That part is a little bit of blind procedure. So I grab a part of the tendon or the extensor retinaculum. So a patient like this, and I redo the procedure. But after I change, I learned from this failure. I changed to the procedure from starting from the MCU portal to STT portal. There's nothing on the STT portal. So if you see the needle tip on the MCU portal, you should be just fine.
Great talk, Joo-Yup. Interesting.
Thanks.
Greg.
May I ask one question for Joo-Yup?
Yes.
Yeah. Actually, a very nice, interesting technique. Two questions. One is, do you apply in all stage? I mean, in all chronicity type of the scapholunate injury, in acute and also in chronic? And secondly, because your suture was actually passed between the scapholunate, apart from tightening the DIC, is that also a direct stabilization between the scapholunate? Is that also part of the scapholunate ligament dorsally?
So the reason I started to do this type of surgery is that I found some patient who has both scapholunate instability and lunar tricuspid instability. And I also use this technique for the lunar tricuspid instability as well. So I just want to make a connection between those two as a seesaw. So I strongly believe that the triquetrum acts as an active engine for the extension of the scaphoid during the ulnar deviation. So we all focus on the scapholunate itself, but I think it's just like a hinge between the scapholunate, but lunate doesn't have any power to extend the scaphoid. So biomechanically, and it's a little bit distally located. So it make a little deeper, and it might push the scaphoid a little volarly, but actually I've done this procedure for the static instabilities as well. But the problem is it was very hard to reduce the disease deformity with this procedure alone. So I have to think more about these severe problems.
Okay. Well done, Joo-Yup. Beautiful presentation.
Thank
Unless
you.
there's any more questions, I think we might get PC to share with us his concept of using the box treatment. PC, thank you very much.
Thank you. So I just go with that. Thank you, Greg, for a kind introduction. And first of all, I would like to really thank all my friends in the IWAS, Max, Christophe, and also particular thanks to Fernando, because he was the first time to join our APWA-IWAS meeting. So it was a great sharing of idea and experience among the two different continents. So it's a really wonderful beginning. I'm talking about my concept and technique of scapholunate reconstruction using tendon graft in an arthroscopic manner. The inspiration starts with these papers published in 2000 by Dr. Molim's groups, I think in New York. And basically, it was in the cadaver. Basically, if you pass a tendon loop around the scaphoid and the lunate, and then tighten it, it's basically effectively reduce the scapholunate diastasis and also improve the scapholunate contact with the radius. But since then, there has not been any clinical study, although similar concept have been done in the 70s by Linsha and Dobbin, but end up into failure because of the open surgery, too much damage to the scaphoid. The arthroscopic era actually enabled us to perform this sort of box reconstruction, I call it dorsal and volar reconstruction, using in a more safe manner, because in the arthroscopic assist approach, we can preserve the capsule, preserve the very important vascularity, and then we just make the bone tunnel under image control, and we can make a more precise image controlled tunnel creation. And then the reduction and the visualization of the joint can be helped by the arthroscopic wheel. So we can actually see clearly the instability and also the reduction of the scapholunate joints by the tendon graft. So this enabled this surgery to be performed safely and effectively in those cases, even the chronic case. First thing, you have to be ensure the reducibility. This is still the prerequisite. If the scapholunate joint cannot be reduced, it may not be a good procedure. I like to using this radial deviation view to demonstrate the reduction of the scapholunate gap. And also in some case, if you can easily push the scaphoid and reduce the DC deformity, it would be a wonderful case. But not all the cases, of course, like this, but arthroscopy actually help to do the capsular release, and this intra-articular manipulation actually help the reduction even in some difficult cases. The tunnel position actually matters. In the scaphoid tunnel, we are drilling from a dorsal distal to a volar proximal, and we think that we don't need anything more than 2.5 millimeter in order to minimize the damage to the blood supply. Of course, this is in the reference of our patient in Hong Kong, and this is the typical location where you can put the lunate very close to the proximal pole. On the contrary, the lunate tunnel will go the direction in the dorsal proximal to the volar distal. And you can see that when these two convergent pins was equalized, the scapholunate DC deformity can often be reduced nicely and anatomically. And with the small grasper, you can actually see the tendon graft can be passing through this tunnel relatively easily. And this is a very strong and sturdy reconstruction of the volar part of the scapholunate ligament, which is also not only to enhance the scapholunate stability, but because it actually includes the capsule. The capsule does not need to be reset or to open. So it actually augments the extrinsic ligament. And the reduction can be seen easily when you actually put the back into the arthroscope. You can see by pulling the tendon, the scapholunate joint reduced nicely and evenly. And when you relax the joint widely open, and afterward, we just suture the tendon in the maximum tension, and this actually helped to restore the stability of the scapholunate joint. So here you can see some of the cases even with a very wide diastasis of the joint and dorsal translation. This technique can effectively restore the complete stability of the complex, and also with minimal scarring and a very excellent functional outcome. Another case with a very wide diastasis, dorsal scaphoid subluxation with this technique done almost 9 years, 10 years ago. This is a case by Dr. Chair, and you can see it's a wonderful clinical restoration of function, and also no deterioration of the alignment of the scapholunate joint even after more than 10 years of time. This technique was first published in 2015, so this is 6 years ago. And so essentially, that series of case, majority are Geisler grade 4 lesion. We follow the patient for about 4 years. Essentially, all patient has improvement in the pain score and also the wrist functional score, improvement brake power, and also reduction of the scapholunate interval from 5 millimeter to around 2 to 3 millimeter. And interestingly, comparing to pre-op, there's actually improvement of range of motion, which is rather unusual for those scapholunate ligament reconstructions series, because most of the series will report a reduction in the motion, particularly in flexion, and the complication is relatively limited. Today, I would like to share a little bit more in detail about the surgical technique. The
typical incision extends from the 3-4 portal, about 1 centimeter radial and 1 centimeter outer. This is a ECRB and this is a ECRL. And usually, just between these two tendon interval, this will usually locate the best interval for the proximal scaphoid, prepare for the tunnel. So this extensor retinaculum, the fiber. Okay. Now there's two ways: either you retract all the extensor retinaculum to one side, but more commonly, actually, I go through the EDC tendon, splitting between 2 of each of the component. So I think basically we have already roughly identified the lunate interval and also the scaphoid interval. Our interval is FCR tendon and the palmar longus tendon. Now I make an incision on the palmar side, palmar cutaneous part of the median area. The assistant need to be identified, understand what the interval we are talking about, so as to prevent the injury to the important median nerve on the outer side, the flexor tendon on the outer side, and also the FCR and radial artery on the radial side. Okay, now the dissection is ready. We go to the X-ray to prepare for the bone tunnel.
You can see the scaphoid is quite unstable vertically. Okay.
Okay, let's see.
Yeah, looks all right.
So let's see the lateral view.
Yeah, actually quite nice.
Now the pin is already through the volar side, and then Dr. Wong is just checking whether there's any important structure like the nerve or the vessel is being impinged by the pin.
The margin, I would say a little bit dangerous. If you can go to a bit more distal, will be probably be a bit safer.
So let's change a bit the direction. Totally. Good, very good. I think it's okay. And then the AP view.
Yeah, I think fine. Now, at least we are quite safe. We are not really close to the articular surface.
To do the lunate tunnel.
Yeah. So we'll try to get to the center of the lunate, which is usually the ideal tunnel. Yes, looks quite nice. Okay.
If there's no DC deformity, the two pin can be slightly convergent. If there's a significant DC deformity, they will need a larger degree of convergence. Okay, now checking the positioning of the pin. Yeah, it is very nice. It is more or less in the center of the lunate. And when we go to the lateral view,
yeah, I think it's fine. It is actually roughly in the half of the lunate position. And you can also see that the two pins look a bit convergent. So imagine that when we are equalizing, the DC deformity can possibly improve a bit by this convergence of the pinning.
So now we can enlarge the hole with a cannulated drill. So we start with a 2.0 cannulated drill. In order to prevent the pin from pulling out, we have to grab onto the opposite side. Yeah, so now you can freely drill the bone. Basically, after the first pass, we will just continue. Yeah.
All right, thank you. So now we have this 2.5 millimeter tunnel. Okay, we'll just check a little bit on the positioning on the hole size. Yeah, I think the hole is in a nice position. Yeah, we can clamp it. Now we are making the tunnel for the scaphoid. Okay, start with the 2.0 drill first, and then complete it with the 2.5 millimeter drill. Use small arthrotomy, okay, where the pin goes through. Is have to make sure that the hole will be good to see. Oh yeah. So now I make sure I completely engage into the scaphoid tunnel. Now I can using this grasper to pass on the palmar-spongus tendon graft. Okay, now the graft is smoothly passing into the fluid tunnel. Okay. Try to come out. Okay. Okay. Tunnel. Yes. Okay. Okay. Now we completely free the tendon graft from the ETC. We can remove this tendon loop. We will go underneath the ECL L tendon. So we still have an EPL tendon that we need to pass in through. Okay, now the remaining thing will be a small part of this retinicular fiber. Okay, so you can see the free gliding of the tendon into this tunnel. So we will try to make like a shoelace. Now before we tying, we will bring up to the scope to check the reduction. Before it's very high up in position because it's unstable, and you can see that the gap is widely open, and then the scapholunate is very loose. Now Corella was holding this the tendon graft, which has been placed in a shoelace manner. Now with the pulling, you can see that clearly the scaphoid drop down, and the gap is much tighter, the volar side. And I see the dorsal side. So this is the dorsal side. Yeah, it's equally stable, and I try to push it. You can see both. Now, with if Corella relaxed the tendon graft, the joint fell into unstable position. The gapping, the riding position, etc. Now, if I pull the tendon graft, everything come back in a nice position. Okay. So that will be finished by suturing the tendon in the maximum tension. I usually tie in 2 square knots. Making 3 knots will be too big, and people will not be happy about the bow. And at the end, we just repair the retiniculum and suture the skin. And you can see that actually the whole thing is quite invasive. We do not open the capsule at all, and that is the beauty of the surgery. So I found my technique is applicable for Marcus stage 3 and stage 4, where the scapholunate ligament is not repairable, whether there's a DC or deformity, but they have to be reducible. Sometimes even in stage 5, where the reducibility is questionable, but this can be actually helped by the arthroscopic approach. We can render many of this stage 5 disease into a stage 4 and make the surgery again feasible. So thank you for your kind attention. I wish today's sharing can give you a little bit better understanding about my technique and also the application. And I welcome continue to support APWA, and hope to see you in Shanghai this year. I personally also wish to see you when done. Okay, thank you very much.
PC, very nicely shown. I think that video helps to demonstrate some of the finer points. So thank you for sharing that. Just one comment from some of the work we've done with our anatomy. I wonder whether you can make your scaphoid drill hole a little bit more radial and a bit more distal. It might make it a bit safer for the proximal pole. And then, in fact, I think it will help reduce it as well. That might be a comment to think about. But,
well, actually, I want to emphasize this point very much. Indeed, I showed you that the hole cannot be too close to the articular margin to run the risk of fracturing. And so I think at least 2-3 millimeters from each side of the margin would be a very wise choice.
Yep, that sounds good. And I think the way that you tie it down, it takes the dorsal and volar capsules down onto the scapholunate interval, doesn't it?
Yeah, sure. They also include those extrinsic ligaments as well.
Yeah. Max, have you got any questions?
Yeah, how long do you immobilize all this?
Yeah, generally 6 to 8 weeks, depending on I usually will cast at least for 6 weeks, and at 6 weeks I remove the cast and check if the patient is already quite stiff. I may start some gentle motion, but if the patient is reasonably well, I keep for 2 more weeks. So in general, I seldom more than 8 weeks.
And what we have discussed before, this little DZ deformity, these fixed positions of the DZ, do you try to correct this before you do the reconstruction, or is that not a problem?
I just need to make sure that the DC is reducible, at least in using imaging to check whether it's reducible, and also arthroscopy to see the dorsal step and the position. But in very severe case, I also don't hesitate to temporarily reduce the DC by doing the Lin-Shan maneuver, pinning the radius to the radius to the lunate, and do the subsequent work. But it's very important that by the time when you pull the tendon, you have to remove the pin first, because otherwise the lunate will be too stiff, and it may not be possible to push all the scaphoid back to the lunate. You have to make the two bone mobile before the tendon. So that is the only key point I want to point out.
Thank you.
Good. Are there any more questions for PC?
Yes. Yes. Oh, sorry. PC, do you have a fracture of proximal pole or lunate, and how you avoid that?
I remember I have one patient, which is actually I placed it too close to the articular margin. When I reviewed the patient, actually I found there maybe a little bit breakage of the cortex. And in fact, that case also lose a little bit of the reduction, although the patient subsequently is okay. So that's why after that case, I will be very careful not to be too close. When I say that, it's at least 2 to 3 millimeters from each side, distal, outer, and proximal. It's very important to prevent the fracturing.
As usual, as for the scaphoid non-union treatment, the most difficult part is to place correctly the cow wires.
Yes, it's true.
Okay. I think in sake of time, thank you very much, PC. That's was really a great talk. And again, this technique is saving us for so many problems we have. I think we can go on to the next step. And welcome, Fernando, Corella. Good morning. I think it's your turn now to explain us arthroscopic assisted volar and dorsal scapholunate reconstruction with FCR tendon. Okay, Fernando.
Yes. Can you see the screen?
Yes, we can.
Yeah.
And we hear you.
So first of all, thank you very much for the invitation and to participate in this webinar between APWA and IWAS, and for the opportunity to talk about a technique that we have been working on since 2010. At that moment, the common technique for a reconstruction of the scapholunate ligament was a dorsal ligamentoplasty performed through an open approach. Also, at that time, there were arthroscopic techniques, but most of them consist of debridement, electrocoagulation, or KY spinning. So we asked ourselves, why not combine the benefits of the two techniques and describe a technique that combines a ligamentoplasty in an arthroscopic manner. That was an arthroscopic scapholunate ligamentoplasty. So where we were designing this technique, we tried to obtain some goals. The first one was to obtain a less scar tissue, but even more important than the scar tissue was to respect the proprioception. As there was no need for an open capsulotomy, the posterior interosseous nerve will be respected. This was our first paper in 2011, the cadaver study, and we checked that there was no injury of the posterior interosseous nerve in any specimen. Initially, the technique was described to perform only the dorsal reconstruction, but a few years after, we described a modification to reconstruct also the volar portion. And we think this is important because if only the dorsal portion of the ligament is maintained, as is in this specimen, This movement is not a void, and neither is a rotational movement a void. So reconstruction, also the volar side, will improve the biomechanics of the joint. And this was confirmed by this paper performed by Samet Walker and his group. They analyzed different techniques and conclude that the stronger one and the one that resembled better the native scapholunate ligament was this double dorsal and volar reconstruction. The last goal was to allow the patient to move early, allow an early mobilization protocol. And to do that, we have to stop using KYS and use interferential screw as are commonly used in many other joints. So nowadays, we allow a patient to make a mid-carpal motion only 2 weeks after surgery, a complete range of motion at 4 weeks, and we will begin the proprioception exercises at 6 weeks. So this is the technique, reconstruction of the dorsal and volar side of the scapholunate ligament fixed with 2 interferential screws. And this is a clinical result of a patient with a complete range of motion only 3.5 months after the surgery. You can see there the scars of the technique. So in the next minutes, I would like to focus on these 3 topics. And maybe the most important one is the indication, because if you want to obtain a good clinical result, it's important that the patient fulfill these 4 criteria. The first one is that it should be a complete and chronic injury, as in this case, with no remnant of the ligament to make a suture. If there is a remnant of the ligament and the degree of the instability is lower, I totally agree with Dr. Mathoulin and Max Haerle. I will go for a capsuloplasty. The second indication is that the instability should be really easily reducible. Only with the probe, the scaphoid should be positioned back to its normal position. In this case, you cannot perform this technique. Also, you should not have degenerative lesion. This is a slack grease, and you should go for another kind of technique. And finally, there should be no lunotriquetral injury, because this is not a scapholunate instability. This is a more complex lesion. This is a floating lunate, but also you can do an arthroscopic ligamentoplasty. We have just published this kind of technique for an S-shaped ligamentoplasty reconstruction that can reconstruct also the scapholunate and the lunotriquetral ligament. So let's move now to the surgical technique. The incisions and portal used are the radiocarpal portal, midcarpal portal, and a small dorsal central incision. In the volar side, 2 radial incisions for retrieving the graft, and another volar central incision that is the same approach that we use for the volar central portal. The technique can be divided into 4 steps. The first one is the bone tunnel. We do a 3 millimeter bone tunnel in the scaphoid and in the lunate. The second step is the preparation for recovering the graft. We pass a loop from the dorsal incision to the 3-4 portal. And the third step is the graft passage and fixation. The graft is a 3 millimeter hemitendon of the flexor carpi radialis. It's passed through the scaphoid, and while traction is applied from dorsal, the first screw is introduced from volar. Now the loop is the graft is captured with the loop and taken to the dorsal central incision, and again through the lunate bone to the approach of the volar central portal. Now, while traction is applied from volar, the scaphoid is supinated and the second screw is introduced from the dorsal side. And the last step is the volar reconstruction. We pass the graft under the flexor tendon and over the capsule and attach it with a small anchor to the volar side of the scaphoid. So this is the reconstruction, dorsal and volar. In the last 5 years, in order to increase the strength, we are using now a suture tape. The technique is exactly the same. The tape passes along with the tendon graft, but after the graft is fixed to the volar side, the tail of the tape that exits from the scaphoid tunnel is not to the tail of the tape that exits from the lunate tunnel. This is a really short video just to show you the most important steps. This is a grade 4 instability of the scapholunate ligament. First tunnel in the scaphoid, second tunnel in the lunate. Now the graft is captured and taken to the 3-4 portal, and while traction is applied from dorsal, the first screw is introduced from volar. Now the graft is passed through the lunate tunnel along with the tape, and now you can see how when tension is applied, the DC deformity is correct and the step off between the bones disappears. So maintaining traction from volar, the second screw is introduced from dorsal. And the last step is the volar reconstruction. We introduce a small anchor in the volar side of the scaphoid and make a suture of the graft. And finally, we knot the two tails of the tape. So this is the patient graded for instability. That was before the technique is performed. And on the right side, after the technique, there's no gap between the bones. A big step off between the bones that is totally reduced after the technique. And the most important thing is that the dorsal displacement of the scaphoid and that big gap totally disappear and all the proximal row move together. So let me finish with the clinical results. And for that, I would like to show you these 4 examples. The first one is the patient that was the pain, the grip force, and the measure of the dust. And you can see a really good clinical result in motion. Consider the scars and an improvement in the grip force. Another example, again, patient with a lot of pain, but with important strength, 50 kilograms. Again, a really good clinical result in motion and an improvement in more than 10 kilograms in grip force. Another patient, less pain, but with a low grip force. Again, really good range of motion and an improvement more than 10 kilograms in the grip force. And the last patient, this is my strongest patient. He has 62 kilograms pre-op. That is the range of motion. After surgery, you can see the scars, and 91 kilograms with ligamentoplasty. So this is really an important report. But why I have shown you these 4 clinical results? Well, I have shown you them because 2 of them have an excellent X-ray and 2 of them don't. So which one of them? It's really difficult to guess which one is the bad X-ray result. Well, there was the 2 on the top. You can see a gap after the technique. So I think it's really important to talk about this because I no longer believe the gap is a problem. I think that many patients with an increased gap really do well after many techniques for scapholunate reconstruction. And I think this is because the problem is not the displacement in this side, it's not the gap, but the dorsal displacement of the scaphoid over the dorsal rim of the radius that make this impingement. So it doesn't matter if you have a gap, the problem is the dorsal displacement. If any technique corrects that dorsal displacement, it will work well. Up to date, we have operated 46 patients. So these are the results. But the pain improved after 3 to 6 months and continue improving in the first and second year. The grip force is normally more or less the same after 3 to 6 months that pre-op and improve after 1 to 2 years. And the DAS value also decreased in the 3 to 6 months and continue improving after 1 to 2 years. And what about the motion? Is similar to the pre-op. Maybe some less degrees in the 3 to 6 months, but at 1 year, most of the patients reach the pre-op motion. So the take-home message I would like to give you is that I think this is a good technique for advanced cases. You will have less scar tissue, so better range of motion. You will respect the proprioception, and you can allow the patient to move early. But if you want a good clinical result, you should maintain or adhere to these 4 indications, and always please talk to the patients about the gap. Explain him or her that maybe he is going to have a gap after the technique, but it's really probable to have a good clinical result despite of this gap. Thank you very much.
Thank you very much. That was a lovely presentation. of one of the more modern or sophisticated techniques. Very interested in your comment about the X-rays, and we've certainly seen that with some of our cases as well. Can I ask you, if the patients, a lot of them have mainly a dorsal instability and not really much volar instability, do you ever just do the dorsal aspect of your reconstruction and not bring it back to the scaphoid? And do you think there's a role for that?
Yeah, I normally do all the reconstruction, dorsal and volar. And I think the scapholunate, when you have a rupture, the rupture begins in the volar side, and you see that always in a distal radius fracture, scaphoid fracture. The first part that is tear in the scapholunate is the volar portion. So normally, when you have a dorsal rupture of the scapholunate ligament, most of the cases also have a volar instability. So that's why I think it's important to reconstruct not only the dorsal, but also the volar side. And that also improves the stability between the bones. So for me, it's better to reconstruct both portions of the ligament.
I have a question to PC and Fernando. It's a great lectures, so I've enjoyed a lot. Actually, I have a question about the volar ligaments. I think the radioscaphocapitate ligament and the long radiolunate ligament might be relaxed with the severe type of scapholunate instability. So it's also, I also found that very frequently see the TFCC tear at the scapholunate. That explains a lot with the hyperextension injury. Is the triangle, big triangle and small triangle may be torn. And the volar radial ganglion, that's why volar radial ganglion is so common on this side because of the tear. So I just want to ask you, both of you, which ligament will be more important?
So you means important to the scapholunate joint stability?
Yes, yes.
I think recently, Scott Woods and Charles that actually the long radiolunar ligament is carry an important role in the stabilization. And it also makes sense because it's actually closer to the scapholunate joint comparing to the RSC. So I think if you strictly speaking, probably that one is the more important. But as you see in my reconstruction technique, I would say that because I basically the tendon when we're passing outside the volar side is actually passing through the volar ligament together with the capsule. So probably in respect, I do not do very meticulous which tendon I loop in, but basically I believe most of the RSC and also the long radiolunate will be included into this reconstruction. That's why it reinforce the volar ligament pretty well. So I think, and also I think if we really want to do a decent reduction of the gap, although I agree that with Fernando, that the gap itself may not be so important, but the gap is part of the instability pattern. So it would be nice if we can do that. So I think it's still believe that you need a very strong volar reconstruction. Otherwise, just a simple dorsal reconstruction, it may not be possible to really bring the whole gap together. But the dorsal reconstruction is very important because, as you said, we prevent the dorsal translation, which is the single most important factor, which may lead to persistent pain and also advanced degeneration. So if we can successfully stabilize the scaphoid to maintain in that position, that will be always the goal of many reconstruction surgery.
I think the radioscaphocapitate and the long radiolunate ligament are not lax. When you make the exploration at the beginning of the technique, you can check those ligaments, and I haven't found, I never have found any tear in those ligaments or even a laxity. So I think it's important, as PC explained, just to tight all the capsule. And I am sure that the same way is a dorsal complex, is a complex in the dorsal side of the scapholunate, I'm sure there is a volar complex in the volar side of the scapholunate. So always tighten the capsule, I think it's a good idea. In fact, our technique goes under the dorsal intercarpal ligament, but with the tape, you can also go over it, because many surgeons have asked me, why don't you go over the capsule as PC Ho does? So with the tape, you can do also, instead of going inside the joint, you can do the technique over the capsule and also tension the dorsal intercarpal ligament.
I would have a very short question for final question to Fernando. Fernando, you use these interference screws to block your tendon, and I think that's a critical point of all of these procedures. Did you have any problem with the interference screws, that they were or too small or too big, and did you have any breakage of the bones?
No, I haven't had any bone up to date, but one surgeon from Chile told me that he has one. But many years after the technique, it was a patient that do a lot of grip force. He was a kind of sportsman, and after a fall, he has a break in the lunate bone, maybe because of the hole, and the lunate is not as strong as a normal lunate. But I have no problems with fracture preoperatively, but some problems with the screw because it's really difficult to find the hole. So sometimes the screwdriver can break and you have to remove the screw. That's difficult. And in one patient, I have to remove the bollar screw because it was moved out of the hole.
Yeah,
but only I have to remove that screw in one patient.
Okay, thank you.
Could I ask? Could I ask
Good morning, Jan.
Could I ask a question for Fernando? I saw you're using a suture tape. I've seen once that the suture tape works as a jiggler saw. It will enlarge the holes. It's very strong. And I saw you put the suture tape inside the peak screws, which may help. And as if you stabilize the graft and the suture tape, maybe it will help. But I will warn colleagues to use the suture tape because it could work as a jiggler saw and enlarge the holes and break the bones. So I'm a little bit reluctant to use that. PC will never use it, and for the PC's technique, he doesn't use any screws, interference screws. And if you add the suture tape to PC's technique without using screws, you will end up in trouble.
Yeah, I haven't had that problem, but I have heard about that because it's a really strong threat. So maybe you can have that problem. What I have seen, because now we have a follow-up of 10 years in some patients, that the hole increase in the X-ray. After some years, the hole is bigger, but I haven't had any fracture or also with the tape. But that I think that also happened in the knee and in many other ligamentoplasties through the bone. The hole after some years increase. So what is happening inside that is the graft just sticks to the bone. We really don't know, and maybe the answer is no.
Okay, we might finish up there, Fernando. That was really brilliant talk, and probably where we're going to be going more and more, I think. So thank you very much for that. For our final presentation, Andrew Chin from Singapore, providing us a presentation on the anti-pronation tenodesis. Andrew, if you can share your screen, please.
Morning, Andrew.
Morning. Can you hear me and can you see the slides?
Perfect.
Yes.
All right.
Nice view.
So I stand between you and the end of the lecture or end of the session. All right. Thank you very much, ladies and gentlemen. Good morning and good afternoon to all the audience. Today I'll be sharing on this rather complicated technique of spiral tenodesis of the wrist. This is probably why it's given as a last talk, because this is actually quite a difficult surgery to start off with, and but the indications for this procedure is pretty specific, and I'd like to share with you when do we actually contemplate using this technique to treat some of our patients who with very bad scapholunate instability. All right, I want to pay tribute to Mark Grasser Elias. He's actually the innovator as well as someone who actually thought about this technique, and he has graciously shared with us when he came to Singapore some time back. Right, not too long ago, this tree ligament tenodesis was developed to address dynamic scapholunate instability. Right, but dynamic scapholunate instability in the presence of undiagnosed extrinsic ligament injury, if you apply this 3LT procedure, is doomed to fail because you have not addressed the extrinsic ligament instability. It's like trying to build a house on shifting sands. Of course, you know, this is what happens. So we introduce this new technique called a spiral tenodesis. As you can see from the cartoon, what we do is that we use a tendon graft to recreate a series of ligaments to stabilize the wrist. All right, and this precisely addresses the situation that you just saw earlier on. So why spiral? Well, this is the concept of the biomechanics of the wrist. When there's loading of the carpus distally, what happens? The distal carpal row will go into pronation, and then the proximal carpal row, which namely the scaphoid and the triquetrum, will act in opposite directions. The triquetrum will be in extension, whereas the scaphoid tends to flex, and the lunate in between tends to ulnarly translate. So this concept of a spiral tenodesis, what happens is that we studied the ligaments and we found out that these anti-pronation ligaments actually help to stabilize the wrist, and they constrain the disc displacement, namely the dorsal scapholunate ligament, right? The scaphocapitate volare, the dorsal intercarpal, both the dorsal lunotriquetral as well as the volar lunotriquetral, and the long radial lunate and the radial scaphocapitate. So these are the main ligaments that help to constrain the wrist during loading, right? And it forms a spiral, as you can see from the diagram. So my slides are not. I'm sorry, but the slides are not advancing.
Perhaps if you close. Oh, now it's going.
Now it's going again. Sorry about that. Yeah. So as you can see from this illustration, there's the spiral configuration of these ligaments that I talked about. Right. So what you can see is that initially the 3LT procedure actually only satisfies one half of the spiral complex, whereas the other half has not been described, and this spiral tenodesis procedure will be the one to actually complete the whole entire procedure. Right, so briefly going to the surgical technique, this concept was again initialized by Mark Garcia Elias. So during the cadaveric dissection, when he was with us, right, he actually showed some of what happens when he does the spiral tenodesis. You can see the whole entire wrist complex is actually very stable and very, very snug. So this actually proves that the ligaments are, the tendon graft actually helps to sort of address the ligaments that are torn, especially both the scapholunate as well as the extrinsic ligaments. Right, so in 2012, we wrote a paper using FCR as the main tendon graft. And Sanjeev Kaka and Mark Garcia Elias actually in 2017 sort of suggested that we use the ECRL tendon in place of the FCR. The reasons being given that the ECRL extends and supinates the scaphoid better than the FCR, which is also an important scaphoid stabilizer, and you don't want to violate it as much as you can. Right, so this is what happens if you use the ECR. So it actually extends and supinates the scaphoid well, and of course it's also a longer tendon compared to the FCR. So in this step diagram that you can see, the ECRL first is harvested, and then scaphoid tunnel is drilled right from volar to dorsal, and then you pass the ECRL tendon graft through the tunnel as it exits dorsally. And then you stabilize the scapholunate joint with K wires, and you drill the triquetral tunnel as shown, and you pass the graft from dorsal to volar through the triquetral tunnel, stabilize the LT joint with K wires, and then you pass the remainder of the free tendon graft beneath the flexor tendons, and you anchor it to the radial styloid volarly. So this you can see from the axial view, a stepwise projection and of the ECRL graph that traverses from volar to dorsal, and then again back from dorsal to volar, and it anchors at the radial styloid. So forming a very nice spiral configuration, and also addresses the incompetent ligaments such as the SL as well as the extrinsic ligaments in patients with a severe scapholunate instability. So a case illustration. First of all, we need to know what are the indications for this technique. In chronic peroneal instability, the following issues: complete and irreparable rupture of the SL ligament complex. And the secondary stabilizers are either insufficient or torn, such as the STT, the scaphocapitate, RSC, as well as the DIC ligaments. The lunate is unstable, as you can see from the X-ray when it ulnarly translocates, or is grossly malaligned from the loss of ligamentous restraint. And of course, the carpal misalignment has to be easily reducible, and the articular cartilage should not show any degenerative changes. So in this case that was illustrated as a 43-year-old construction worker who fell from height, resulting in this he presented at a chronic stage with this severe scapholunate instability. It was reducible, and that's why, and there was no articular cartilage involvement. So an ECR tendon graft was used, and this is some of the pictures showing the surgical procedure. And this was actually at 17 months post-op. You can see that the tunnels are still visible. And then these are the clinical results. It's pretty good for 17-month follow-up following someone with a chronic severe scapholunate instability. All right, so one more thing. Thanks to our European colleagues, there's an arthroscopic option available actually now. It's been developed, and you can see these portals are actually used for the procedure, both volar and palmar. So both dorsal and palmar. 1, 2, 4, 5 MCU portals are the viewing portals. The 6U, the volar radial, as well as the mid-carpal radial portals are used for the suture loops to guide the tendon graft deployment. Yep. So these are actually some of the incisions that are recommended, making it actually a limited open technique as well, because you need to pass the tendon grafts around the dorsal as well as the volar aspect of the wrist. So there are a few incisions, small incisions that you need to make in order to achieve that. Right. Of course, we use the Nakamura wrist drill guide to help us to create the bone tunnels. Here is a triquetral tunnel. And here's a scaphoid tunnel that we actually require the use of this wrist drill guide to help us. And of course, suture loops are important, and suture loops that are passing from the volar radial to the 6U portal, as well as the 6U portal through the triquetral tunnel to help us to fish the ECRL tendons and to deliver them to form a spiral configuration around the carpus. Right, as you can see, and also suture loops are also required to pass through the scaphoid tunnel, right, initially to pass the ECRL graft from volar to dorsal after it has come from dorsally through the STT joint. And of course, we harvest the ECRL graft and use it, and after passing through the STT joint from dorsal to volar, we then proceed on to put the ECRL graft through the scaphoid tunnel that's created, and we pull on it to reduce the scapholunate junction. And so the ECRL tendon graft traverses from volar scaphoid through the dorsal, across the scapholunate and the lunotriquetral joints, straddling the DIC ligaments, and then comes through the triquetrum dorsally to volarly, and then right across the radial carpal joint to the radial styloid. And this actually straddles the long radial lunate as well as the radial scaphocapitate ligament. Sorry, for some reason it's not advancing.
click on the slide once again.
Yeah, okay, sorry. Yeah, all with the help of the suture loops, they're pre-placed to deploy the ECRI graph. And of course, if you can see from the picture, you can see the suture anchors as well as interference screws are strategically located at these regions to actually stabilize the reconstruction. And thereby, by doing this, you actually recreate the DIC, the dorsal scapholunate, the volar lunotriquetral, the long radial lunate, and the radial scaphocapitate ligaments, which addresses this actually forms the anti-pronation ligaments that actually help to stabilize the wrist. Okay, because it acts as a restraint to the pronation torque during the loading of carpus. So what are the advantages of this arthroscopic reconstruction over the open? First of all, it's less trauma to the soft tissue. Most of the joint capsules are well preserved, and nerve, especially the PIN, is not sectioned when you are using, because the open technique you actually use the burger capsulotomy, and there's a risk of sectioning the PIN, which may actually have some effect on the patient post-op. And no K-wires are used like Fernando's cases, and this actually helps to facilitate early mobilization. Okay, so in summary, when the wrist is loaded, inherently the carpus, the distal carpal row pronates, the scaphoid flexes, the triquetrum extends, and the lunate tends to translocate ulnally. So competent wrist ligaments, they form a spiral restraint to counter the pronation torque during loading. For some chronic peroneal instabilities, they result in chronic scapholunate ligament rupture with associated incompetent secondary stabilizers and unstable lunate. You offer them this spiral tenodesis, which helps to restore the anti-pronation restraint and also address the instability. The prerequisite, as mentioned earlier, is to ensure that there's no degenerative changes of the articular cartilage, and the carpal misalignment can be easily reduced, because if you fail to adhere to these strict indications, the procedure may not work. And of course, now there's an arthroscopic option that's been developed and will soon be published. So I'd like to acknowledge both Dr. Mark Gracia-Elias and Dr. Andre Artse, who are both innovators of the open as well as the arthroscopic technique. Right, I welcome you to Singapore in 2023 for the 8th edition of APWA as well as the 13th Asia Pacific Federation of Society of Surgery and Hand meeting. Thank you very much.
You're on, by the way. Andrew, well done. Very nice presentation. In your practice, so which technique do you tend to do if you see a patient who's got a 3-month-old scapholunate instability that's quite wide? Are you doing this the open way or arthroscopic, or are you doing something else in your own practice?
No, I mean, of course, this is a very specific indication. I don't tend to do this case unless, of course, I mean, I've assessed the patient and found that the secondary stabilizers are indeed incompetent, and indeed there's a lunate translocation. Then these are the indications, clear indications I will offer. Otherwise, I'll be doing the one that the PC, Fernando, and the rest advocate. Yeah.
Okay.
I would have a question to all three of those reconstruction authors, PC and Fernando and Andrew. Andrew, great talk. Fernando stretched out that the fact that a little gap remains is not important. The important thing is to stabilize the proximal pole of the scaphoid, avoiding that this ridges over the dorsal ridge of the radius. Is that true in your experience too? And some people tell us, well, your repair is not successful because your radiographs don't show the success. How do you answer to them?
Well, I mean, I agree with Fernando in a sense. Actually, a lot of us are very obsessed with the gap, but actually, more importantly, is the clinical outcomes. So if the gap is still present and yet the patient does not have any pain, he feels better than his pre-op status, I think you can say that, even though there's still a gap, but certainly, the whole complex actually stabilized in that sense. Yeah.
Yeah, I think when we are looking to the gap and obsession with the gap, we are looking to the wrong side, because I think many techniques has demonstrated good clinical results despite a gap. So is, for me at least, is for the dorsal motion of the scaphoid over the dorsal rim of the radius, and you can check that with the Watson test. And if your patient has a gap but don't have a Watson test and goes well, I think it's a successful technique. But you should talk before the surgery with the patient, because he has visited many surgeons before you, and all people have talked about the gap. So I think we have to teach them that the gap is important, but it's not essential for a good clinical result. So for me, obviously you prefer to have a perfect X-ray, but many times you don't have a perfect X-ray, but you have a perfect clinical result.
Yes, I would like to add something. All these techniques are very beautiful and very convenient for us, but we don't have to forget that our way of teaching is to discover this lesion before, at the dynamic stage, and to treat them in order not to see this kind of patients in future. Maybe it will be not the case, but I hope so.
Totally agree.
I think I have already answered to your question before. That I think dorsal translation is now worldwide recognized as the single most important factor which determines continuing pain. Yeah. So I think that one you need to the number one priority you need to address. Whether the gap, yes, because there's so many studies in the past, so many techniques actually in fact fail to consistently reduce the gap, but many of them consistently give rise to good results. So that means that the pattern leading to pain clinical stability cannot be judged by the gap alone. So I think that's also very true. So it's the overall complex, the stability of the complex in 3-dimension manner, or even in 4 dimension, when the time during the use of the tech is the matter a lot. But having said so, I still have to remind you that the most easy way for the patient to judge your technique is to look at the gap. Because every time
yes,
but they can see the gap, and they ask you, doctor, why the gap is still so big. So you need to prepare to answer this, and that's why some patient education is also important.
Yeah, that's why you have to talk to them. If you have a big gap before surgery, talk to them about the gap before surgery, because after surgery he thinks you think it's not important, but all the previous surgeon has taught me that the gap is the main problem of my wrist. Yeah, and talking about the gap, all we know, if we want to close scaphoid with the lunate, what is the best thing? A compression screw, no? Crossing that. And all of us know what happened with a compression screw, because there is motion between the bone. So I think we have to forget about closing this way, but avoid the dorsal displacement. Yeah.
Yes, and then I think doing this discussion, probably we have also to come to another view of diagnosis, because if the gap is not the important thing, then also the diagnostics and everything changes. So that's an interesting trip we are going into.
Yeah, that is why I think the Gregory Bain 4D CT scan is really important to check that dorsal displacement of the scaphoid, and in which position, if it normally maybe is in hyperextension, the displacement, the dorsal displacement is more important, or in grip front, and maybe to check the good result of the technique, we should do this for the CT scan after the technique.
The gap is not important, but the stability is important.
Yes.
Sometimes you have a gap with a good stability between the scaphoid and the lunate, and it works very well, and the patient has no pain. So the most important is to obtain the stability.
Yes.
Unfortunately, because like what you mentioned, the patient always looks at whatever is visible. So the gap is obviously the most important thing to the patient, right? But then, of course, we all know that the most important thing is not the gap, but as you all mentioned, the stability, as well as to address the other stabilizers as well. Yeah. So counseling, as what Fernando said, is very important. So I always counsel my patient, because I will tell them not to expect the gap, but actually to look at the rest of the clinical outcomes like pain and grip strength and range of motion.
Yeah, and I think it's important to show different things with bad X-ray in meetings. I mean, I think we should share more awful X-ray with good clinical result, because I have talked with many surgeons, and I think it's a common thought, no, that we have many patients doing well, but the X-ray, you want to lose the X-ray and cover them under your desk.
Okay.
I think we're just about done, aren't we, Max?
I think so. From the IWAS side, I think that was a great experience, and I'm extremely happy about this co-joint meeting, virtual co-joint meeting. Thank you all. I'm a little bit. I think we can encourage more our European colleagues to be present in early morning on Saturday, but that's something to be improved next time. And thank you very much, Greg.
Max, thank you very much as well, and the whole IWAS team and APWA team. I think it's a very important day in our progress. So I think we hand over to the presidents, Wendong and Toshi, to close off the webinar and thank everyone concerned. It's been a great event. Thank you.
Yeah.
Thank you.
Thank
Congratulations.
You, yeah, you organized a very nice webinar in this afternoon, and also that thank you for attending the European people in early morning of the Saturday. Then that also that I would like to ask Wendong to close this webinar with an advertisement of the his 2021 Shanghai APWA Congress. Wendong.
Yeah, thanks everybody. So this is a very successful webinar. This is our first IWAS and APWA combined. Picture. Really enjoyed this moment. So as I think I am both in the IWAS side and the APWA side. And this year in November in Shanghai, we hope the COVID-19 will go, and we will have a face-to-face physical meeting, and all the IWAS IWAS members and APWA members, we are welcome to enjoy together in Shanghai. So we hope this moment will be true. Thank you all. We will close this IWAS and APWA webinar. Thank you all.
We'll be there. I hope.
Could we do everyone puts their camera on?
Yeah, open the camera.
Everyone puts their camera on?
Yeah.
They're all sleeping, you know.
Let's have a picture.
Few more.
Few more. Okay, 1, 2, 3.
My
Nice.
grandson.
One more.
Nice one.
Oh. Great. Yeah. Thank you, everyone. Thank you. Thank you.
Thank you, everyone. Thank you.
Have a very good weekend. Thank you, everybody.
For the organization. Perfect.
Bye-bye.
Goodbye. Have a good day.
Well.